So while you guys are waiting, I'd like to mention that we do have an open Q&A forum tonight. We have a wonderful presenter on this evening that's going to be giving you a ton of information. So at the end of her presentation, we will take questions. On the Zoom platform, there's actually a Q&A button. If you can use that Q&A button to ask your questions, it's a great way for us to actually receive a recording of your questions. And if by chance we're not able to get to your question tonight, we'll make sure to get back with you via email. So I'd like to tell you a little bit about our presenter this evening. Leslie Stevens is actually the CEO and president of HealthyStart. She's actually been involved in the world of pediatric sleep, breathing, and airway for over 35 years. She's an international lecturer and trainer, and quite honestly, I don't think there's a question in reference to the subject of pediatric sleep, breathing, airway, and HealthyStart's connection that she cannot answer. And really, when you have the backing of a company like HealthyStart by Orthotain, you have over 51 years, over 4 million cases, and tons of research to back you. You know, most importantly, she's a mother of 3. So her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. And one of the things you're going to learn tonight is that there is a silent epidemic affecting 9 out of 10 children. This epidemic manifests itself in a variety of symptoms that can easily be overlooked, misdiagnosed, and most unfortunately left untreated. So it's absolutely critical that children are evaluated for sleep and breathing habits. Leslie's mission is to educate both dental professionals and parents to ensure children a lifetime of health, happiness, and success. So I'd actually like to take this time to hand the floor and the mic over to Leslie Stevens.
Thank you so much, Susie, and welcome everybody. I am thrilled to be here. As always, I love to basically take the opportunity to educate all of you in something that is just so true to my heart, but more importantly, so important, especially in this climate. As we'll start talking tonight, I would love for you just to sit back, just take it in. These are recorded. You can always get a recording of it, but I always like doctors to just kind of absorb this information. This is a lot to take in. This is probably something new, something that you probably are not familiar with, or maybe if you are, you just don't have as much information in the pediatric world. I'm just pleased to present this, and please ask as many questions. This will be a brief overview. Obviously, I'll try to go into as much depth as I can. But I want you to have that aha moment tonight. So many people do, and I just am anxious for you to see what we have to tell you tonight and maybe change the way you look at kids. So anyways, tonight we're going to give you HealthyStart. It is about a comprehensive system taking you from education and screening to evaluation and treatment. As you all are probably aware, the ADA did pass policy about a year and a half ago, a year ago this past October. And basically, it does require each and every one of dentists to evaluate children. And you're going to screen them and look for improper growth and development and airway issues that are prevalent within these children. So how do we do that? What are we looking for? Maybe some clues that can help us identify maybe some areas of improper growth and development, areas of poor habits, and probably most importantly, improper ways of breathing or not getting enough oxygen as we breathe. So some of these outward symptoms that are more easily recognizable and should provide that clue for not only you, but also parents to evaluate further. So we realize, and research has shown us, 9 out of 10 children will suffer from one or more of these outward symptoms. And these outward symptoms include mouth breathing, snoring, teeth grinding, swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, hair problems, few friends, bedwetting, difficulty in school, especially in the subjects of math, science, and spelling, delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently waking up at night, sleep talking, and walking. So I would call these outward symptoms, which I'm sure all of us can identify in so many children that either we're involved with or our children are involved with. We see this all the time. It truly is a silent crisis among children. And I would basically go beyond America's children. It is globally. I am leaving for Albania in about 2 weeks. Same issue. I was in Manila, which was kind of shocked. We had 1,100 doctors come to our presentation, and unfortunately, there were 600 waiting outside who were not allowed to come in because we ran out of seats. So you see this situation no matter where you are, and it's critical that we understand and can identify these outward symptoms. And then we'll talk about what we do at that point. So, as a parent, I probably do see a lot of these outward symptoms in my child, but I probably never realized that maybe they're connected. Maybe there's a link between what I'm seeing. So, typically, a parent will see an asthma, a child that's struggling possibly with ADD and ADHD. So, we're going to look at it as an isolated outward symptom, and we're going to address it in a variety of different ways. Lots of medication, testing, counseling, therapy, surgery, sleep studies. There's a variety. The problem is that we're going to have these children that might have 3 of them. They might be on 3 different medications. They might be on 4 different medications. But what is common is that unfortunately, many of these medications only address symptoms. They don't look at the root causes. They tend to be short-term band-aids, and they often involve several drugs with many side effects. And unfortunately, these drugs can be costly, painful, time-consuming, and ineffective. So tonight we're going to take a look at these outward symptoms as outward symptoms. And we will explain how we look at the root causes and what these root causes are. And typically, we see that these are related to mouth breathing, narrow palate, improper tongue placement, and poor jaw relationships. So let's take a look at, first of all, how do we screen? First evaluation really is just appearance, visual. Let's take an assessment of a child when we see them. They provide you with a ton of clues. So let's take the girl on the left. Take a look at her face. Look at the venous pooling or the circles under her eyes. Look how her chin is lurched forward. We typically see children that are struggling to enlarge their airway, typically move their head forward. Look at the boy on the right. Again, circles under their eyes, venous pooling. Look at the separation of their lips. Look at the rolled lip. This child is probably a mouth breather. Take a look at the way the neck and the chin kind of almost appear as a double chin. This child is not heavy. However, the improper growth of the lower third of the face has made it look like he has a more full or a double chin situation going on. Let's take a look at the profile of children. As we take a line, we can actually go down from the forehead down the face. You can see how deficient this child is in the lower mandible. Obviously, you can see a rolled lip. The rolled lip basically indicates that you probably have more of an overjet situation. We have a separation of lips, typically a mouth breather. Take the girl on the right. Let's do the same exercise. Take a straight line down her forehead. Again, so much deficiency in the mandible. You can see that the chin blends into the neck. Sometimes we call that a funnel look. You'll see the rolled lip, not so much separation, but with that rolled lip, I would anticipate probably a large overjet. See circles under their eyes. These are all things that you should take an assessment of before a child actually gets into the chair. So you're already in your mind thinking about 5 different things that you see in that child that's going to lead you to probably realize that because of the lack of development, because of these improper habits, we're going to have more health issues. So we're going to ask for further screening, and we're going to ask a parent to help us. We have the HealthyStart Sleep Questionnaire. And what makes this so unique is that it basically is going to have a parent evaluate the top 27 outward symptoms of sleep. And they're going to look at the initial column, which means prior to treatment. And we're going to ask them to give a degree of severity for each symptom. So we're going to have them rank these conditions from 0 to 5, 5 being the most pronounced. Once we start treatment, we'll have them reevaluate that, but we'll talk about that later. Another interesting notation is C number 27, speech problems. We see a lot of speech problems associated with this. And why is that? Because the habit, the tongue is not in the right position. Tongue tends to be low, which goes hand in hand with the mouth breathing. If the tongue is low, the tongue has lost a lot of its strength. So it's not in the proper position to make sounds. It doesn't have the endurance to make the sounds. So a lot of that complicates the speech issue for these children. HealthyStart did a large sleep and screening research study that studied over 500 children. And they evaluated looking at the sleep questionnaire. And the results of this research indicated mouth breathing and snoring are commonly associated with more sleep disorder symptoms than any other symptom studied. 9 out of 10 children had one or more of these outward symptoms of sleep. 60% of the sample had 4 or more outward symptoms. 1 out of 5 children experienced bedwetting. I think I'll make a little note about this. Unfortunately, we don't talk too much about bedwetting. I was shocked when I saw that 18.6% of the children in the study at a later age still bedwet. And we have found that bedwetting does go hand in hand with sleep issues. And realizing that this many children are struggling with this is kind of important. We have been looking at sleep. We've been evaluating sleep questionnaires for quite some time. And I'll be the first to say a lot of parents might fail to fill that question out. They might be embarrassed. They might feel, well, really, what's the dentist? Why would I inform a dentist that my child bedwets at a later age? So typically in that situation, when we see a sleep questionnaire and there's a lot of outward symptoms, I would use a third person analogy and just say, typically with a lot of these outward symptoms that we see apparent in your child, sometimes we also see a situation of bedwetting. And the important thing for parent and patient to know is in many situations, we're able to alleviate that problem. And immediately you'll see the eye contact the parent and the child will have with each other. So I just bring that up because it's always good to know what outward symptoms we have prior to starting treatment. This last point is so critical, and it's between the ages of 4 and 12. 92.6% of the outward symptoms will not self-correct, and 30% will worsen with age. What does that mean? That means that the percentage is so great that we are not going to self-correct these outward symptoms. And a parent should know that. So I say, when we identify these symptoms, we need to treat them. What's the probability they self-correct? Less than 8%. That's not a great odd to basically base a decision as important as this is. So that's a really important statistic. So I suggest if you're going to write something down, maybe write that down. That's important. So let's talk about these different outward symptoms. We talked about mouth breathing being the most prevalent. You'll see 43% of this study were mouth breathers. The reason why mouth breathing is so critical is that by just opening your mouth by a half an inch, you're basically going to reduce your airway by 6 millimeters. Why is that important? Well, let's take a 7-year-old. A 7-year-old's airway is typically about 7 millimeters. So what does that mean? If they're a mouth breather, they're reducing that airway down to 1 millimeter. What is 1 millimeter? It's basically nothing. Have you ever tried to breathe through a coffee stir? That's what 1 millimeter of airway looks like. So it is a huge situation. Are the children getting enough oxygen if they're trying to breathe through 1 millimeter of airway? Most likely not. Does REM sleep require oxygen? Absolutely. Are these kids that have these reduced airways that are struggling to get enough oxygen able to get into REM sleep? More than likely not. So that's the critical part of this conversation, how mouth breathing is such a critical habit that we need to alleviate in these children. So on average, if we see a child who mouth breathes, we will typically see 8 other outward symptoms. And these 8 other outward symptoms can be snoring, difficulty listening, often interrupts, talks while sleeping, allergic symptoms, fidgets with hands, restless sleep, teeth grinding, feels sleepy and irritable during the day. So let's talk about the implications. The findings show that sleep disorder breathing is much more common and affects children even as young as 2 years of age. I will actually challenge that to now say we have even studies that show that these issues can even be apparent in a fetus prior to birth. So we know it starts extremely early. So knowing that, we encourage every parent to be evaluating their child. But if they come in to see you, even at age 2, our youngest patients are 13 months. We have 6 of them. So even if you have a young child, if they're mature enough to be able to hold a pacifier, they'll be mature enough to hold an appliance like this. So we need to get started. When we see it, evaluate it, treat it. That's the progression that should be occurring. The second bullet, begin treatment as early as possible. And the last, identifying outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. No longer is it just about the teeth. It's about the entire child. And that's what we should be evaluating. So let's talk a little bit more about airway. Again, we had talked about the importance of an appropriate or a normal sized airway. What's normal? Well, in a child, we say typically if we look at the top of their pinky, that should kind of resemble what that airway should look like. Sometimes we tell a parent our goal is to create an airway as big as a hose. We would love to have that. If we mouth breathe, you can explain it's almost like trying to kink that garden hose. And that reduced airway is similar to a coffee stir. I'll tell you, I did a experiment one day. I thought, well, if kids are trying to breathe through 1 millimeter of airway, I'm going to try to do this, see what it really feels like, and see what these kids are experiencing. So my plan was to spend the entire day breathing through a coffee stir. Well, probably got about 10, maybe 15 minutes into it. And I'll tell you, I had the most massive headache I've ever had. I tried to take Excedrin. I tried everything. You know, the only thing that worked was going to bed that night, getting a good night's sleep, and waking up in the morning. Well, that was possible for me. Unfortunately, most kids don't have that ability. This mouth breathing happens each and every night. So they never have the ability to regain what they've lost. So this is part of that important conversation that we hope to have with parents. Again, another way to look at it, here is a visual of what a 7 millimeter diameter airway looks like with 100% airflow in a 7-year-old. Still not too big on this right-hand side image. Now, remember I said if you're a mouth breather, you're going to take 6 millimeters away of that airway. And look what we're down to, 1 millimeter. Pretty small. Maybe a little bit bigger than a pinhead, but not much. Really small. So parents typically, maybe even you're asking, why is this all of a sudden becoming an epidemic? Why haven't we heard this before? Well, we find that a lot of this, or the contributing factors that we see, include prolonged use of pacifiers, prolonged use of nipple bottles, lack of breastfeeding, soft diet. Genetics probably plays a role in it. We do know that approximately 21% of the population will have a skeletally narrow airway. It's a good fact to know, especially if you're working with CBCT scans and Cephs. Um, Obviously, it's an upward position, but we kind of know what we're in for. Well, let's talk a little bit about these other um, outside factors that have contributed. Obviously, in today's society, most parents work. Very difficult for a mother to basically breastfeed their baby for 2 years. Extremely difficult. Some mothers will say, you know what, I couldn't breastfeed them, but I pumped and I was able to provide breast milk to them. That's great. The problem is the mechanism of delivery. So, nipple bottle, a pacifier have the same properties. One, they're going to depress the tongue. The tongue is not going to be in the right position, which is on the roof of the palate. When we say the letter N, where that sound ends should be where your tongue is at rest. Most people's aren't. So I don't know if all of you are trying it, but I can guarantee you, most of you who are listening tonight, you're going to be a little bit concerned because probably that's not where your tongue is placed. So the pacifier, the bottles, that keeps depressing the tongue. Now the tongue isn't in the right place, but it doesn't have the ability. The tongue is our most powerful muscle, and it probably doesn't have the strength nor the endurance to be placed in the upper palate. And if it's laying low, the tendency is to mouth breathe. The same thing, breastfeeding actually helps develop that oral cavity. We're not having that opportunity in a lot of these children. Soft diet, well, if we look at cavemen had a very tough, rigid diet, which basically required the oral cavity to really use that chewing motion, and that helped develop the arches. It helped to develop the oral cavity. Well, with this soft diet, we're not using the chewing muscles that we should be using in order to develop the oral cavity. Look at here, graduate puffs, a nutritious snack that melts in a baby's mouth. That kind of sums it up, doesn't it? What else are we looking when we look at these kids? Well, if we see an open mouth, a tongue thrust, these are all possible indications that it's a pacifier or prolonged nipple bottle use. Also could be a result of finger sucking, thumb sucking, any of those. So, orthodontic conditions also play a role in what we're identifying, but understanding how detrimental the use of pacifiers, nipple bottles, um, lack of breastfeeding, soft diet play in the role of this conversation. Important to just kind of have just an overview of the anatomy of the airway. We want to look at the nasal cavity, hard palate, soft palate, the tongue placement, obviously the airway. We talked a lot about the mouth. Now we need to talk about the importance of nasal, or the nose. The nose really has 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane traps dust, bacteria, and other foreign matter. It contains receptors which sort out odors. It aids in pronunciation and the quality of voice. These are all extremely important. And obviously, we want to make sure we educate parents when we talk about eliminating mouth breathing, but encouraging nasal breathing, and explaining what the importance are of the nose. How many times have we seen this? A child, I want to preface this child, the car is stopped. Yes, the safety belt is behind them, but it was only because it was stopped and she was sound asleep. But look at the mouth. The mouth is open. She is mouth breathing. As we found out that 43% of the population basically does exhibit mouth breathing. So I want you to take a moment and listen to Eli. This is going to basically sum up why mouth breathing is so critical. But I want you to pay particular attention of what this mom does and how the facial appearance of Eli changes. Up.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway, I'm opening his airway, pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
So wow, right? Now, we see what the problem is. Now, what if we could create a system, a series of appliances that would be able to produce the same outcome? Not only would it prevent the mouth breathing from occurring, it would basically promote that growth and development in the lower third of the face, teach the child the proper position of the tongue, start expanding the arches in order to accommodate the tongue and the upper palate, all while the child sleeps. So that's a preview of what we're going to talk about with the Healthy Start. These are exactly the principles that are going to be addressed. It's almost like a 3D type of system that will address these issues. So let's talk about what exactly is going on in the airway. So here are two 5-year-olds, two different patients. The child on the left obviously has a restricted airway. Now, as I said before, we're only as good as our tools. This is a CEF, we have a CBCT, are typically the two types of evaluations we can make on an airway. And the problem with both of these tools are we're going to be viewing that child in an upright position. So this is the best it's going to be. Once the child is horizontal, the muscles tend to relax, and the ability or the probability of that airway closing further is greater. So when we look at these, we say best scenario for that child. So the child on the left, you can see, has a compromised airway and is one of those 21% of the population that will exhibit a compromised airway. The child on the right has a normal airway. This is what we would anticipate seeing. Now, we talked about the child on the left. Wow, it looks great. Normal airway. We should be fine. Child has all these outward symptoms. Well, probably a habitual problem. Remember, we talked about the mouth breathing. If we open the mouth a half an inch, look at the closure. This is the same patient. So you can see the effect that that habit has on the airway. This is an interesting case that was treated with the HealthyStart. And we have a way of determining what we would consider an average airway. And typically it's starting at age 5. You multiply the age by 10 will give you that airway. So for instance, this patient is 9 years old. So we would anticipate 9 times 10, a 90 square millimeter airway. Unfortunately, this child only has a 53.6 square millimeter airway. So they're deficient already. So in this particular case, the first appliance was given to them and they wore it for 1 month. And we wanted to see exactly what and how great of an impact were we having on the airway. Now, there's more to the treatment than 1 month, but this is the initial. So here is that same child 1 month later. Not only have they increased their airway 6 times what we anticipated, they went from 53.6 to 337. But let me tell you why that number is astounding. Typically, at age 17, we find that we peak in our airway development. So we would anticipate an adult at age 17 to have an airway approximately between 150 and 170 square millimeters. Now at age 21, guess what? Our airway begins to deteriorate, and it will deteriorate over the course of our life. So we anticipate an adult, if they reach their maximum, to reach 150 to 170 square millimeters. Look at this child. That's double. What will that mean for his life? We don't have all the answers yet, but this is the research that we are currently conducting. So we can see what the longevity is of this type of development, how stable that development is. And obviously, we want to see what that health of that child looks like during the years that come. So many of you, maybe you work right now with adults with sleep apnea. Obviously, at that point in time, we're going to start evaluating that patient's airway. It's already compromised. But the $1 million question was, did they ever reach their potential of 150 or 170 square millimeters? We don't know. Maybe they did. Maybe 150 to 170 is not enough for a lifetime. We don't have those answers yet, but this is the conversation that we're starting. So you can see this is exciting. This changes, this is the game changer. So anyways, I bring it up so that you can start thinking in terms. Here's just a schematic of what we just talked about. So let's kind of review the cycle of events that occur. So mouth breathing and snoring, we realize it's usually a result of extended bottle feeding and pacifier use, causes poor tongue position and abnormal swallowing. Sugar processed foods can have an effect. Poor oral habits, thumb, finger, lip sucking, tongue thrusting, etc., can lead to a compromised airway. A compromised airway reduces airway, restricts airflow, reduces oxygen, increases CO2, affects brain function, immune and endocrine system, swollen adenoids and tonsils, low tongue position, tongue thrust, underdeveloped dental arches, overjet, open bite, even crossbite. And this leads to what we call sleep disorder breathing. And sleep disorder breathing is basically identified with restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmares, daytime drowsiness, aggression, difficulty in school, frequent infections. Here was a study that basically took a look at MRIs. The first 3 images are MRIs of an individual that had a normal night's sleep. And you can see the amount of activity that occurs and the brain function. The next 3 images are after 1 night of sleep deprivation. And you can see very difficult. I think there's one area here that has brain function. So you can see the impact just with 1 night of deprivation. So we can all kind of relate to that. How many all-nighters did we pull in college? Probably a bad thing. And we knew it would, but part of the issue was the brain activity. We impacted that the following day. So let's talk about Healthy Start. What are we going to do? How are we going to do it? Interesting new area. How many kids are affected? Well, right now, Healthy Start, Orthotane, has been around for over 50 years, and we've treated 4 million children worldwide. We realize that today there are 40 million children impacted by sleep, breathing, and airway issues just in the United States. Huge number. What does that mean for you? Well, in your community, are you going to be the hero? Are you going to be the educator? Are you going to bring this epidemic to light? Absolutely. Absolutely. This is, I hope, one of the reasons you became a dentist. We want to help these kids. We want to help our neighborhood. We want to help our community. And educating in this area is just a phenomenal way to really change the trajectory of so many children. So now what happens? Say you have a child that comes into your office who's age 5. How is a Healthy Start? What are we going to look for? We talked about going ahead and do the evaluation. We're going to take a visual account. We're going to screen with our sleep questionnaire. And then we're going to look for the underlying root causes. We have diagnostic sheets that we will fill out to help us with evaluating these children. And then we'll begin treatment. And treatment typically includes about 3 appliances per patient. And each appliance has a specific purpose. And it is going to create the growth and development as that child is growing. So the first appliance is typically what we call a habit corrector. And it is what it says. It basically is addressing the habits. So whether you're a toddler, a child between the ages of 4 and 7, a preteen, or even a teen and adult, we have a corrector for you. And it's basically based on age. Then the second appliance, if a patient is 5, will be the C series. And it will be basically helping to guide the dentition, expand the arches, correct any overbite, any overjet, open bite, cross bite, class 3, all of these issues with passive nighttime wear. Then as the laterals start to erupt, obviously childs become mixed dentition. We move into the next appliance, which will basically be addressing that child during that period of time and continuing with the same, expanding the arches, correcting the function, jaw relationships, and obviously straighten the teeth and continuing those habits, providing the proper habits for those kids. So as we said, Healthy Start is addressing the root causes, and these are expanding the dental arches, establishing nasal breathing, training the tongue, eliminating bad habits, advancing the mandible to correct the overjet, encouraging proper facial and body growth, and correcting most orthodontic problems. Sometimes we say straightening the teeth is kind of the frosting on the cake. So let's talk about habit corrector, the first one. Why is this so unique and what sets it apart? Well, it has built-in myofunctional therapy. The appliance is designed and is activated by a swallow. So there are palatal tabs, sometimes I call them expansion tabs. So as the child puts their tongue up, it will actually expand the arches, creating a space for the tongue to be able to be positioned in the palate of the mouth. We also have little prongs here that prevent that tongue thrust, but also indicate to a patient when they should retrieve their tongue. We have a lingual shelf. It's more like a ramp. So every time the child swallows, the tongue goes up the ramp to the proper position in the upper palate, expanding the arches and swallowing in the correct position. We also have tabs on the lower portion. So as the child's wearing it at night, it will not allow that lower chin to drift back. Even as we're working on eliminating the mouth breathing, even if that child opens that mouth, those tabs will keep that lower chin forward so that we don't have an opportunity to kink that garden hose or kink that airway. We want to encourage that the child is learning the proper swallow. How do we determine if a child has an improper swallow? Have them have a glass of water. Watch them swallow. They should have no facial movement. All the movement should be here in the neck. If you see the mouth making all sorts of movements in order to get that swallow, you already know they have an improper swallow. I would continue each and every appointment to have them have that glass of water, see how much improvement we're making with that swallow. As I said, these myofunctional therapy, the position of the tongue, the expansion, all of this is occurring because of the swallow. And we swallow approximately 1 time a minute at night, 2 times a minute during the day. So what does that mean? That means at night, each and every night they're wearing this appliance. They're going to be repeating those habits 500 times. Imagine if you did exercising 500 times, how in shape we would be. It's exactly what's happening to them without them even knowing it. So we're able to make these changes in such a dramatic fashion in a short period of time because we're basically creating the proper environment that nature should have created and allow the body to be basically promoting the growth, eliminating the improper habits, giving them the proper habits, expanding the arches all at the same time. So it's a phenomenal type of treatment that requires little exercises, little implementation from the parent. The parent does have to make sure the patient wears it at night. But let me tell you, it's better, it's more comfortable, the kids like it, they say it's squishy, it feels better than a pacifier because it's helping them. It's making them feel better. So our cooperation rate is high. We get 94% cooperation. Now, you might say, well, you're going to say that. Why not? Well, we had one of the largest orthodontic studies done in the country of Finland. They actually did 3 cities. And guess what? Their cooperation was 94%. We did that same study at Tufts University, and guess what? 94%. I actually think we're higher than 94%, but I'm going to go with 94%. But we'll explain. We really make you very efficient in this system, and we make it a lot of fun. A research is coming out on 220 patients and what they accomplished in 5 months using the habit corrector. And we wanted to give a gauge so that you as the dental provider will have a gauge of how much correction on average do we see. If a child is not gaining that correction, we need to have a conversation. Let's see what's going on. Maybe there's something we're not recognizing. But the results were pretty astounding what we could accomplish in 5 months period of time. So let's take headaches. Headaches, out of the sample of 220, we found that 18% had headaches on a routine, on a daily basis. That represented about 40 kids. And we found 98% of these cases had improvement. 94% mean correction of those improvements, 91% mean correction of the entire sample, and 85% of the cases with 100% correction. So you can go through this. Here are all the lists that you'll see in the sleep questionnaire, but it will help you gauge and give an idea of what we're seeing. Obviously, we will get better and better with the more information we gather, but this is the beginning of those kind of statistics because let's face it, we want you to be successful. We want each and every patient that leaves your office to be a perfect billboard for your practice and for the HealthyStart treatment. So we are going to gauge so that you are successful. And that's what we're anticipating by giving you that kind of information. ADD, ADHD, and sleep disorder breathing. This is a huge topic. I think we all could have this conversation that it seems that ADD and ADHD that diagnosis is at epidemic proportions. I I hear so many kids being diagnosed. And interesting enough, the most recent research showed that 85% of children with ADD and ADHD had sleep issues. 85%. Why is that? Well, interesting. ADD and ADHD is not a blood test. It's a list of criteria that a child must exhibit in order to gain the diagnosis of ADD and ADHD. Well, what's interesting is that same list of criteria is the same criteria we use to evaluate sleep disorder breathing. Can they be misdiagnosed? Absolutely. So what the outcome is, it's not to say ADD and ADHD doesn't exist. I think the discussion point is, if you have a child that exhibits ADD and ADHD behaviors, evaluate sleep first. Sleep can be the reason that these behaviors are, or maybe they can contribute. So you don't know which way it's going to be. But if you evaluate, you look for the underlying root causes, we address those underlying root causes, let's see where the kid lands. So there have been some very exciting research done on ADD and ADHD, and probably the most significant was by a researcher by the name of Karen Bonnick. She basically evaluated over 13,000 children, and she found that sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. She also found that ADD and ADHD patients have little or no REM sleep, but they have delta sleep. Patients without ADD and ADHD have primarily REM sleep and delta sleep. In the research that we did on 500 children, we found that ADHD was present in 25.2% of the cases. Here are some very significant percentages. So when we talk about ADD and ADHD, we find that 50% of those children who have been diagnosed with ADD and ADHD are held back 1 grade. 30% are held back 2 grades. I got news for you. If the child has sleep issues, you could hold them back 10 grades. It's not going to change it. They're going to continue with that same symptoms. So again, so important, evaluate sleep first. What happens with the kids that have sleep issues? Well, they did a study to reveal that children with sleep disorder breathing have 10 to 20 fewer IQ points. Now, in my world, I would probably say, wow, that could mean my kid maybe wouldn't go to college. They went one step further. They evaluated what the value of an IQ point was. It's $170,000 over the lifetime of a child. It's crazy. Another important statistic to provide to a parent so that they can make the appropriate decision for their child. So how does HealthyStart promote growth and development? Well, as we all know, craniofacial growth typically occurs very early in age, and at around 12 years of age, we see most of the growth completed. So that's why when we look at a HealthyStart patient, we start as early as possible. And obviously at age 12, it gets a little trickier. Some people say, well, do you ever treat adults? We do. Our oldest patient is 84, but with an adult, it's a little bit different criteria because we cannot make that claim that we make permanent changes. We might, maybe 50% of the cases, but because there's no growth and development, it becomes much more difficult. If you're looking at a 30-year-old who has had the same habit for 30 years, it's difficult to change those habits. Are we going to try? Absolutely. Do we have appliances that will help? Absolutely. What's worst case scenario? They might have to wear the appliance every night. But those aren't so detrimental. I mean, obviously we're going to help them. I love the conversation that we can make an impact on a child and make permanent changes. How great is that? I mean, we're going to change the trajectory of their life. We're going to make them healthier. We're going to give them the ability to basically self-correct. and provide the proper habits in the proper oral cavity to give them a foundation for the rest of their life. So with the Healthy Start, we're going to promote forward growth. Here's an example of a case. You can see 5-year-old. Treatment basically took this is about 1.5 years. It's basically during the transition from primary to permanent dentition, which takes about 1.5 years, maybe a little bit longer. And you find that with this forward growth we achieve, we actually, that study in Finland indicated we had 54% more growth opening airway than we do in control samples. So you can see how much growth and development occurs with this system. Here's 2 appliances that are very unique, and they're unique from the standpoint of many times we see the mandible. Yes, we advance the mandible day in, day out. The question isn't what we're seeing more and more is the impact of the maxilla. Not only is the lower jaw deficient, but we see the upper. How do we correct that? Well, we have an appliance called the Max-A, Maxillary Advancer. And how it works is basically there is no frontal wall on this appliance. And we use the tongue. Why not? Most powerful muscle we have in the body. Let's use it for good, right? So we have the child push on these tabs that you'll see here. And they're going to be pushing that upper arch. And as it's driving it forward, that appliance is allowing that lower jaw to move with it. So here you can see an initial case. Here you can see 1 month. Here you can see current. So you can see how we're moving this forward. Now we're going to move it forward, and then we're going to start the habit corrector. And then we're moving into the additional 2 appliances. So you can see it's a process. Now what happens if we have a child with a class 3? Well, there's a pseudo and a skeletal. I'm going to talk about pseudo right now. We can address skeletal, but what we say is we can minimize the skeletal. We might end up in the case with a very minimal overbite, but maybe end to end. Is that better than the class 3? Probably, but we want to make sure parents understand. However, if we have a pseudo class 3, and how you can tell the difference is when you bite down, if you see the child bite end to end and slide down, that's typically a pseudo class 3. If you see a child bite down and bite directly into a class 3, I'd be suspicious that maybe it's a skeletal. So what happens with the pseudo? So what we do, same kind of idea, similar appliance where there's no frontal wall. The tongue is used to push those tabs in a forward direction, and as the lower is being held. So we actually make that jump. And we have the child wear it maybe 2 hours a day and at night. But what's amazing is we make these jumps in like 2 to 4 months. It's quick. I always say, make sure you're watching the patient because you don't want to overcorrect it because it happens so quickly. So you can see, here's one case that obviously did this. I'll tell you a funny story. Actually, this case here, even though it says post-treatment, this was a boy, I want to say 8 or 9, and obviously was very upset about the way his occlusion was. Gave him the the class 3 appliance, told him to wear it 2 hours a day and at night. We'd see him in a month. So this was on a Thursday. On Monday, we got a call saying he was done. All right, come on in. Let's see what done means for you. So he comes in. Sure enough, he had made the jump. Couldn't believe it. How long did you wear this appliance? He said, all day long for the entire 4 days. So that's how fast, that's how powerful the tongue is. So I just bring that up to give you an example of how fast this movement can occur. So treatment planning, as I said before, we do help. We want to make sure that we're looking at all the different orthodontic conditions, occlusion, deficiency, and growth. We're going to look at all of that. And sometimes I say, you know, we talk about the outward symptoms. I think orthodontic conditions I would consider an outward symptom. So that's why we want to be able to identify this, because this is all part of the problem. These are all factors that have to be considered when we're going forward with treatment. So with the Healthy Start system, we will help you with your treatment planning. So as the patients are seen, you will submit cases and we'll assist you. We'll be that consultant that you would love to have in your office. We're going to be that extra set of eyes, hands, ears that can help you, especially at the onset, when maybe you've never seen a child at age 2 or 3, or you've never done anything like this. So it's all a great way to understand how we're directing, how we're monitoring, how we're evaluating what's going on with those kids. So now the fun time. Let's look at some cases and let me show you what we can do. So here's a boy, age 7. Obviously, look at the initial, look at the 4s. Look how many, I think there's either 17 or 18 outward symptoms. That's a lot. That would be a severe condition. Look at number 27, speech problems. Look what the parent wrote, very delayed speech. Didn't say many words up till age 3 or 4. This is a serious case. And so let's take a look. Let's evaluate what else we see when we take a visual assessment. That kid doesn't look too bad. But look at this. Look at how deep that overbite is. Look at the squareness of their arch. Look at the circles under his eyes. So this is March of 2015. The habit corrector was given. This is 3 months later. Couple ones. That's amazing. 3 months. That's what it did. So let's see what his dentition looked like. Here's March. Here's a year later. Look at the correction of the overbite. Look at the changes in the structure of the arch, rounded. Think there's plenty of room for that tongue to go? Absolutely. Look at the child's facial. Look at the changes that occurred. Looks like almost a different kid. So now let's see how progression is made. Here he is a year later. You can see how the teeth have settled in. Again, beautiful arches. Look at the child, totally different. So this is what we're looking for. Here's another child. Again, take a look. Initial, you can see 5s, 4s, 3s. Here's the initial, again, very deep bite. Here's his progress. He's not finished yet. We will monitor these children. Even though we might say active treatment lasts about 1.5 years to 2 years, we do monitor those children till 12. And all that means is they'll wear the appliance at night as kind of a retainer. We want to make sure that the entire 28 teeth are erupting properly. We want to make sure that there's no surprises as we go through, and just passive nighttime wear will do that. Here's another, here's an initial, here's the finish. Pretty dramatic. Here's kind of the process. You can see the deep overbite. Patient is fitted with the appliance. You can see how the incoming permanent teeth are coming in on an angle. They're captured by the appliance and they're basically guided into the proper position. You can see how the finished, and you can see them in the appliance. As you will see, the appliance does change colors. We call it a cooperation detector. As the patient wears it at night, it turns cloudy, just like this. They stop wearing it for 48 hours, guess what? It goes back to clear. So you can always monitor exactly what they're up to. Here's another case, initial, finish, initial, finish. This is an interesting case. Her mother was probably around 35, 37, and she ended up having to have jaw surgery. And she saw her young child have the same characteristics, the same ortho problems that she had as a child. So she opted to do something earlier than later. So if you just had a visual assessment of this child, look at the circles. Look at the way her lip is rolled. You can see that double chin. Look at the dentition. Look how deep that bite is. Look at the squareness of the arch. So look at what she looks like now. Here she is. Different kid. Look at her occlusion. Look at her arches. Now, it's important to understand, I told you that we make more permanent changes. We're guiding the teeth in. You can think of it two ways. As the teeth erupt, those fibers are like anchors. They're going to anchor those teeth in that position. You can think of the fiber bundles as a retainer for life. Why do orthodontic cases relapse? Well, when we start moving teeth after those fiber bundles have developed, which is typically when we start orthodontic care, it's like a rubber band. You stretch it. Once you release that pressure, guess what? They want to go back. What do they say now? 92% of orthodontic cases relapse. Terrible. So now let's look at that child later on. Here she is. We're going to even watch her a little further. This is maintenance without any type of retention. So you can see how well those cases hold. Here's another case, snoring, bruxism, bad breath, ear infections. 1 year later. This is a case from Alaska. Here's another case. Again, you can see outward symptoms. You can see fives. Not as many as that first one, but significant. You can see the occlusion, deep bite. You can see just a year later, not finished, but you can see the squareness of the arch, the roundness. But most importantly, look at the differences that are occurring. And we'll keep eye on this one and we'll continue to give you updates. Here's initial spectrum of outward symptoms, snoring, bruxing. This is mid-treatment. Here's final, 14 years later. Look how stable. So I want to say, we talked a little bit about compliance. We have an app that goes with each and every case. The app is wonderful. It will monitor, so the child will wear it at night. In the morning they wake up, it'll ask them, did you wear your appliance all night? Yes or no. Did it stay in all night? Yes or no. It will remind parents from the original assessment from the sleep questionnaire, have any changes occurred? So we'll know in almost real time when those changes are occurring. At the same time, the child is rewarded. They get a coin they can deposit in the bank. They spend 30 minutes with game time. And then on Friday, we ask them to take a selfie. So every Friday, they're going to take the cheek retractors that come with the app, and they're going to take a picture. Now, for that parent, there's nothing better to see the progress that is happening. Great marketing device. They can tell their neighbor, their nephew, their sister, whatever it might be, show them that progress. All of this information is put into the portal for you so that you can access this information. So maybe the patient comes in for their follow-up. Before they even come into that chair, you've already looked at that app to see exactly the compliance. You've seen the pictures. You already know what that conversation is going to be about. So it's a great tool. It really helps. Kids love it. The information that you can gather is great. It just helps you. For the 30 days you're not seeing this kid, it helps you gather that information. Again, HealthyStart, we've treated over 4 million cases. Please understand this is made in the USA. It's FDA cleared, no latex, no plasticizers. All appliances are BPA and BPS free, phthalate free, no silicone. We regulate ourselves to a class 2 medical device. We are not, that is not necessary in the United States, but we feel it's important. We want you to feel that we are looking at your kids as they are our own. We do everything to provide and to provide our patients the safest appliance that we can have on the market. So that is our mission and our goal, and we want you to be aware of what our responsibilities are and how serious we take them. So what do we do from here? I've given you a brief overview. Hopefully you enjoyed it and you've learned some. But the next step is come join us for a digital class. I'm hoping Susie, if you're there, she can kind of guide you through what this whole process looks like and give you information. But it truthfully is an amazing way to literally have the hands-on ability, the education in order to understand the treatment, but most importantly, to implement it in the most efficient and effective way into your practice. So Susie, would you be able to take it from here?
Absolutely, absolutely. And also, while I'm sharing my screen, I'll mention one quick comment. Dr. Lawrence mentioned excellent summary of what pediatrics dentists see every day. And he's just making a comment in reference to thoughts about starting even earlier than 2 years old.
Wow, I'm glad you asked. In the next few months, you will see where we're heading. And yes, we are. This is a critical time in a child's life, and we are pushing ourselves to go as early as possible. I'm thrilled that a pediatric dentist is here. You probably see this morning, noon, and night. I'm hopeful that you've already been identifying this. If you haven't, tomorrow is the first day of a long journey for you, and you know, if we can be a part, we would love to be a part, and whatever we can do to help you in that journey.
Thank you so much. So I want to tell you a little bit about the digital education platform that Leslie alluded to a few minutes ago. Our digital education course is actually one of the most popular courses I think that's out there right now in reference to sharing this information with dentists and educating them on how to help these kids with their sleep and breathing issues. You know, Leslie brought up the ADA policy. Well, this course actually complements that policy. And that policy actually says that every oral physician should understand and be educated on how to assess these kids. Well, our course actually meets those standards and provides that education for you. So we actually have a course that's going on right now, and it started on April the 1st, which you could actually jump right in and get started. We have a course upcoming May the 20th. Our digital education course is a 6-session, it's a 6-series session. So the way that it works is every Monday, we actually send you out a video. You have the whole week to watch the video. So you can kind of do it in your own time. We have dentists that train with us all around the world, hundreds and hundreds of dentists each course, which is fantastic. But we send you out that series. You have the week to watch the series. And then on Friday, we have a live interactive study club, kind of like this. We go over the highlights of what you watched, and we bring on specialists to every one of our study clubs to talk about things like billing, or how to increase your patient volume in your practice, you know, things like that. You actually receive 2 full cases, so 2 entire systems for 2 children. We want to hand you, and the reason for that is because it kind of gives you 2 different platforms to learn. You know, you're going to get all the education. It's a comprehensive course. It includes every single one of your staff members as well, because we understand the importance of ensuring that your staff members are on board. But we want you to have that hands-on training as well. So we're gonna walk you through, hold your hand as you treat these 2 children as well. And what we understand and realize is, you know, I'm sure that you have had many aha moments tonight, a lot of fantastic information. But the other side of that is I'm sure that there are 2 children in your mind right now that you know need this help. So we're going to send you those starter appliances immediately so you can start helping those kids immediately, and then we're going to walk you through the rest of it as you're taking the course. Now, you also receive a $3,000 voucher to attend a live lecture as well. Again, another learning platform. So you have the digital learning platform, you have the hands-on learning platform, and then you also can come to one of our live lectures and have a different type of learning platform as well. We want to make sure that you get, we want you to succeed, and we want to make this a comprehensive learning platform for you. We want to help you succeed. You're going to receive a sample acrylic stand with sample appliances for your office as well. And as I mentioned, the interactive study clubs that go along with each presentation. So the digital course includes pediatric treatment on sleep-related breathing disorders and how to identify it in your patients. We'll teach you how, of course, how to increase your patient flow. And you actually receive 18 CE PACE credits and 16 more when you attend the destination course. So a little bit about what doctors are saying about our digital course. So we had a doctor in Australia that joined. He said that the digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor in Canada, I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. Doctor in Colorado. Really enjoyed the course. We've identified quite a few patients that would benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we've seen great improvement in his eating. We already have 3 more patients who are ready to start next week. I really like that particular testimony, and I mean, I love them all, but this particular doctor was 3 weeks in. I mentioned it's a 6-session course. She was 3 weeks in, and the reason that the reason she was able to accomplish that is because she started out with those habit correctors. So, there was 3 weeks that these kids were wearing these habit correctors. They were seeing improvement. Their health was changing. Suddenly their headaches were gone. They weren't having nightmares anymore. They weren't bedwetting anymore. Parents notice these things, of course. They see their kids feeling better. They see them doing better in school. They see them happier. So suddenly they're telling other parents, and next thing you know, you have parents calling you, wanting to make appointments for their children. American Dental Association actually took the course, and they said it was ingenious. So how do you get started? So the digital education course is typically $3,400, and then it's $400 to attend our live lecture. But we actually are giving a webinar special, and I know we were just at the IAOMT. A lot of doctors came out and visited us, so thank you for that. And a lot of them are on the webinar tonight. So we'd like to give you that show special. So it's actually $3,400, and then it's $0 to attend the live course. So you're getting 2 courses for one. Very easy to get started, and you can get started immediately. So you can either visit openairwaydentistry.com, and you can actually click on the Register Now button, fill out the simple enrollment form. It's a secure server, and you can sign up immediately, and we can get you started. Now, you'll notice on there it says lecture date. You can either put April 1 if you want to join the course that's in progress right now, or you can put May 20th if you want to join the next course that's coming up. Either way, we can get you started. Or you can contact me directly at slafredo@thehealthystart.com. Leslie, do you have anything you'd like to add?
I would just, again, reiterate how important and how effective this type of digital is, because think of it, how do we all learn? Sometimes the best way is through reading or research. Sometimes it's talking to other professionals to hear how they're implementing, how they are learning these different aspects of treatment. But most importantly is the hands-on. And this digital is able to combine all of that into one and really give you the ability to understand, educate yourself, but implement into your practice. How do I talk to a parent? These are all things that we go over and I think is so critical in that discussion. So I can't say enough about that. And again, I just encourage you, this is too big of a topic. We know how many kids are affected. And you know what I always say, if I can help one kid, I've done my job. But knowing how many kids are out there that are gone with are living life without being addressed or evaluated is really a shame. And it really needs to be something that's brought to the forefront. So anyways, I hope you participate. Let's get the conversation going and let's change your community.
Awesome. Thank you so much. Leslie, I want to thank you for being on tonight, taking time out of your evening to share this important information. And doctors who have joined us this evening, thank you so much for joining us as well. As Leslie said, this is such an important thing. Once you know this information, you can't unknow it. So you know that there's kids out there that need this help, and you now have the tools, and you know that the tools are available to help them. So it's not just about assessing those kids, it's about having the tools to actually fix their problems. So I really urge you to contact us if you have questions. Sign up for the course if you're now is the time. We always say now's the time. There's no time to wait. This is such a big issue. So we hope that you join our team. We have a fantastic team. So we hope that you join our team. And thank you again for being with us tonight. We will send out your CE credits. That should be coming in via email within the next 24 to 48 hours. But if you have any questions, again, please write down my email address and you can contact me for anything at all. So have a wonderful night. Thank you so much. And we appreciate, again, you guys being with us.
Thank you. Have a good evening.
Good night.